Thank you, everybody. All right. Well, we're really excited to showcase some of our local Accords investigators in this next series of talks. Who here has ever conducted a cluster randomized trial? A few of you. Who's ever conducted a stepped wedge trial? A few? The person presenting, that's good. So definitely we're all going to learn a lot about stepped wedge trials here today. And so the way that this next set of talks will work is a pair of a clinical investigator with their biostatistician, or biostatisticians in some cases. And they're going to be presenting case examples and then really digging into the details of the design and the statistical analysis of the respective trial designs. So our first speaker will be Dr. Allison Kempe, who you heard from earlier. She's the Accords director. I'm not going to read you their bios. They are in the workbook on pages 6 through 8. So go ahead and take a look if you want to read more. Allie is going to be talking about her immunization delivery work, of which she is well known for nationally. And she is paired with her biostatistician, Dr. Miriam Dickinson, who's right here. And then after that, we'll be learning about stepped wedge designs with a case example from Dr. Dan Matlock up there in the right corner there, and his biostatistician collaborators, Dr. Diane Fairclough and Aaron Chelsea. Did I say that right? Good. Okay. And so after these two sets of talks, which will just follow one after the other, we'll have a brief panel discussion where there will be both some planned questions, but also we'll be opening it up to all of you to ask your questions. So if you want to be thinking about a couple questions that you might ask to our panelists, go ahead and do that. So without any further ado, I will turn it over to Allie.
Thanks so much. You know, I just want to say what a fabulous talk that was. Oh, Scott's not back yet, but that was a great talk. Fortunately for you, my outcome is really easy. Did you get a shot or not? So not very hard to understand. But I think this example, I hope, will, in a fairly simple way, illustrate the features of a pragmatic trial, both in terms of design and analysis, and Miriam's going to help us a whole lot with those aspects. So I probably do not have to convince this audience that immunizations are important, because you're all here because you're probably health related. But basically immunizations have been thought to be second only to clean water in terms of decreasing mortality and morbidity for children. Here's a slide showing the % decreases in common vaccine preventable diseases from the time of pre-vaccine era to the most recent US estimates. And most of these are in the 90+% range. And here's another slide showing the common vaccine preventable diseases that we give immunizations for to 19 to 35-month-old children, which is the subject of the study I'm going to discuss. And as you can see, very dramatic decreases after the advent of vaccines. This study, this slide goes to 2010, and we did start to see some bump ups in pertussis, or whooping cough. Those have continued, and if we had another 10 years here, we would see also bumps in mumps and measles, which I'm sure you've heard about for different reasons. In any case, very important problem. So how are we doing? The Healthy People 2020 goal for 19 to 35-month-olds is 80% up-to-date rate with all recommended vaccines. At the time this study was done, our rates nationally were 68.5. They're now a little over 70, but still plenty of room to go. So what is the problem here? We have an incredibly evidence-based approach. Why can't we get our vaccine rates up to 100%? Lots of issues, and I and many other colleagues in immunization delivery work have examined many of these issues. Our job is to figure out why things are not being implemented and disseminated. And here's just a list of some of the issues that have been found to be very important in terms of this problem. And the vaccine hesitancy issues, which you're probably hearing more and more about, are the reason for some of the increases in measles and mumps outbreaks that we see. But a couple of these can be addressed by a fairly straightforward approach, which is reminder recall. That helps people understand. It deals with lack of awareness. It gets them in to see their provider. If the reminder recall comes from a trusted source, it may help with confidence on the part of the parent or patient. And it certainly helps with the issue of complexity and expansion of the vaccine series, because it's very difficult for parents to keep track of when they need vaccines. So one approach I'm going to discuss, and this was the subject of several different trials, are a comparison of two different approaches to increase immunization rates on a population level. So this was a pragmatic comparative effectiveness trial. We didn't just want to compare to usual care. We actually wanted to, from a public health or a public health department's perspective, examine two ways of trying to increase rates on the population level. One focused on one using a population-based approach, and one going through practices. So reminder recalls can be done by a variety of methods, most commonly postcards, letters, telephone calls. Some people are using text now, but that does create some issues that are problematic. But these, if they're reminders, they're informing patients of upcoming vaccines. If they're recalls, these are reminding patients that they are overdue for vaccines. This process can be automated using an immunization information system, or IIS, and that's basically a state registry. All of our states, with one exception, have a state immunization registry. So this can be automated. All of them can do it. All of the state registries can do this. And basically, why do this approach? Well, reminder recall has been studied up the wazoo by me and many other people at the practice level. And what that usually looks like is a study team goes in and they send out reminder recalls, and they do a patient randomized trial, and they show, wow, this is effective, 10 to 20% higher rates. But they leave, after the study team leaves, it is not sustained. So practice-based reminder recall has been shown, and there are 3 Cochrane reviews now showing the effectiveness of practice-based reminder recall. But the fact is, less than 20% of practices do reminder recall. And it seems to be very difficult to sustain, even when you motivate, incentivize, and provide backup for practices. So I spent 10 years working in practices trying to do this, and then I thought, there's got to be a better way. So we reasoned that if we could conduct reminder recall at the population level centrally by the public health department using the IIS, we could reduce the burden of doing this on the part of practices, and we could, as an additional benefit, reach children that maybe weren't coming into the practices anyway. So our objectives were to compare effectiveness and cost effectiveness of these two approaches, population-based reminder recall and practice-based reminder recall. We used a randomization procedure that I'm only going to touch lightly on because Miriam is going to go into some depth about this. But basically, we wanted to, since we are tackling this at the population level, we wanted to randomize whole counties. And with the recognition that urban and rural counties are really different in terms of how their medical care is delivered, we first stratified them. And then within the urban and rural counties, we wanted to balance the counties so that one of the problems with a cluster randomized trial is if you have really imbalanced cluster arms, your results can be really biased and you can't necessarily control for it. So this method was developed for that, and I'm not going to say much more about it because Miriam's going to get into that in some depth, but it's one of the techniques that's been extremely important in helping us do cluster randomized trials when we don't have limitless numbers for example, counties. And so these were the things, the factors here, race, ethnicity, how many immunizations are in the registry, the subspecialties involved, the kinds of practices involved, median income, the number of children in the county, and community health centers. These are examples of things we thought were very important in terms of balancing. Also, the baseline up-to-date rates. Okay, so here's basically the randomization scheme. We had 14 counties available. So again, if you're doing cluster randomized trial, you want to have a lot of clusters. And, you know, we didn't have infinite numbers of counties that were available. Why didn't we? Well, you know, we're in one state, but also we had to exclude some counties because in some counties there were already centralized approaches going on, or the counties were frontier counties. They were, the population was so sparse that they were not generalizable to other kind of counties. And then there was Boulder, and I need to say no more. So we had to exclude certain counties. So here's our scheme. We stratified and then did this covariate constrained randomization that Miriam's going to go into. So basically the Colorado Immunization Information System, this is the pointer here, is fed by birth certificates. When a baby's born, their information goes into the IIS automatically. In addition, practices will put patients in when they immunize them. For example, if they weren't born here, but they came into the county. So that is the way it's populated. It is imperfect in that people can move in and out of state and we wouldn't necessarily know. But that should probably be the same for all the counties involved. And people, you know, kids, if they die, they are removed because the vital statistics does take them out of the IIS. But basically, you know, it's an imperfect way of denominating the population, but it's pretty good. It's about, when they look at it, 90+% of 6-year-olds have all their immunizations in there. So it's pretty good. So we used this data source and downloaded names and addresses of children 19 to 35 months that appear to need one or more immunization according to the IIS. Again, imperfect because not everybody's records are completely up to date in the IIS. So I'm pointing out the pragmatic aspects of this trial. In the population-based recall counties, there was centralized reminder recall conducted by the state public health department. They sent up to 3 mailings to children in these age groups that needed immunizations. The notices recommended they go to their primary care provider, or if they did not have one, they gave information about the appropriate public health site. In the practice-based counties, all practices in those counties were invited to attend a web-based reminder recall training. So this was voluntary. Obviously, we couldn't make practices do things. We suggested in this training the same methodology that was being used in the centralized approach, 3 mailings. And we, in addition, offered some financial support for these mailings to the practices if they did reminder recall. So you can see the pragmatic nature of this. It was from the perspective of the state health department, if you want to raise immunization rates, one reasonable approach would be a centralized approach where the state health department was doing it. Another might be, okay, the practices may do better than we will do. Let's do what we think would be reasonable as an incentive. It couldn't be too high, right? Or it couldn't, or it wouldn't be generalizable or reproducible. But let's see which of these 2 approaches was most effective. Okay, in terms of the statistics, again, I think you're going to deal with this, but basically we did have to account for the clustered nature of the data in terms of children being clustered within practices and within counties. We constructed models to assess the association with the two major outcomes, which were the child became up to date and the child received an immunization. And, you know, another pragmatic part of this is, although we could look to see if there was a new immunization, the outcome also included kids who just became up to date because they brought in their records, which from a public health perspective is an important outcome. Again, very pragmatic. Okay, I'll let you. So we also did a cost assessment. In the population-based reminder recall, this included staff time for training and implementation, staff time for updating bad mailing addresses, and mailing and printing costs. The practice-based reminder recall, we had to rely on the practices to tell us what they did because, again, we weren't doing it for them. We were looking at that pragmatic approach, and we asked them for their average staff time, the method they used, and we gave them compensation for mailing costs or costs of phone calls. So this is the first and major result of this. This is the comparison of the reach of this intervention in the two arms. The population-based reminder recall is on the left, and the practice-based on the right. So as you can see, since we had control over this centralized approach, we estimated that about 85% of children in these counties were reached by this intervention, at least once. 15% that were not reached includes those that had returned mails and we couldn't find an address. In contrast, in the practice-based counties, out of 195 practice sites, only 10 did reminder recall. So the reach was abysmal. Maximum it could have been is 5% because we couldn't get the practices to do it. So that is the most important pragmatic finding from this trial is that approach didn't work very well. Okay, so here are the major outcomes. The percent receiving any vaccine within 6 months, 32% in the population-based counties versus 23% for an absolute effect difference of 9%. And from a public health perspective, that is a huge, huge finding. Percent brought up to date, 19% versus 13%, so a 6% change in the percent brought up to date. So one of the questions is, when I first submitted this article, and this is now 10 years old, so at that time, pragmatic trials were not as ubiquitous, and I submitted this to AJPH. The reviewer said, this isn't fair. You analyzed them wrong because you included the people that never even got a reminder recall. That's not cricket. You know, that's not part of the story. They had no chance to respond to the intervention, which of course is the important part about this being pragmatic. So anyway, the question about does practice-based reminder recall work? Yes, we already have 3 Cochrane reviews saying it does. And here's yet some more data. This is a sub-analysis within the practice-based counties, okay, comparing those rates in the 10 practices that did reminder recall and the rest of them. So as you can see, huge effect size, 12% difference in the percent brought up to date. And when you actually compare the population-based arm, it's even more effective. It looked like it was more effective in the practice-based arm. Now, there's problems with this direct comparison because you're not randomizing the group that chose to do reminder recall. Those are probably highly functional practices that have different patient populations and different providers. But in any case, the answer is yes, practice-based reminder recall works, but on a population level, it doesn't work as well. Here's the multivariable model showing the significant effect size for both outcomes in adjusted models. The costs were also remarkably different. The cost per practice of conducting reminder recall in population-based was $215 versus $1,315 in the practice-based. Cost per child receiving one or more vaccine, $10 versus $38. And cost per child brought up to date, 17 versus 62. So much less expensive to do this in a centralized manner. There are obviously limitations. The population, as I said, was impossible to completely accurately denominate, but the same method was used in all counties, so we don't think that probably had much of an effect. And the population-based approach was probably more hampered by inaccurate addresses than the practice-based approach, because they tended to have more up-to-date information. However, they didn't do very well. And, to some extent, the practice may eventually, if we gave them enough time, have done reminder recall, but actually most of the research we've done since then has not shown that. And costs were based on personnel report rather than observation. So both practice-based and population-based reminder recall approaches were effective. Practice-based approaches may be slightly more effective, although we have not ever randomized that because we can't. However, overall, at a county level, population-based approaches were much more effective and much less costly. I just want to thank my study team and our funders, and I'm going to actually turn it over to Miriam.
All right, hi, I'm Miriam Dickinson, and I was the biostatistician for this trial. And let's see. And basically, what I'd like to do is take the perspective of what are the decisions and the challenges that we had to make along the way as we were designing the trial, collecting the data, and then finally for analysis. So some of the initial study design challenges, early decisions involved what was going to be the unit of randomization. When we initially conceived, when Allie initially conceived of these approaches and wanted to do a fair comparison in a very population-oriented way, what are these decisions? So population-based reminder recall, the intervention was going to be delivered at the level of the population. So we have to think about what's the unit of the population. Practice-based, the intervention targeted eligible practices, that is the training for the reminder recall, and would be actually delivered to the patients by the practices, but we're still interested, the focus is still on the entire population. So keep that in mind. So we knew right away we were going to have to do a cluster randomized trial. Individual randomization was not feasible and really didn't even fit the goals of this study. And so initially, one of the things is power and sample size had to account for clustering. But there were many more issues. So just reviewing a little bit, in cluster randomized trials, many of you have done them. Unit of randomization is a group, not an individual. And groups can be defined in a variety of ways by geographic location, organizational units, even families sometimes. The reasons for a cluster randomized design, this is not exhaustive, but some of the reasons include intervention at the level of a group rather than at an individual. Potential contamination can be a real problem in certain areas with individual level randomization. And sometimes feasibility, well, maybe often feasibility enters into it. There are issues, however. It's not a perfect world. Generally, you have to make compromises when you realize you're going to have to do a cluster randomized trial. The number of units to be randomized is usually fairly small compared to what we're used to in individual randomization. Another issue that can be really problematic is recruiting groups from a larger pool can be challenging, and there can be self-selection. There's a lot of heterogeneity among groups, often, regardless of how they're defined. And individuals within groups are more similar to each other than members of other groups. And this violates some of our basic statistical assumptions of independence. One of the things that affected us quite a bit in this trial is the potential for covariate imbalance between the arms when you're randomizing small numbers. And again, more complex analyses and potentially reduced power. So there are a lot of things to think about. So the first thing we needed to do was decide on the unit of randomization, and we decided the county would be a reasonable unit of randomization. Baseline data could be obtained from CIS, from the CIS database by county of residence, and all children who were in the immunization registry with at least 2 records, who resided in the selected counties, could be included in the trial if they needed 1 or more vaccines. So it's truly population-based. Some of the implications, to think through how this is going to work out in a trial like this. So in the practice-based arm, all eligible practices would be invited to participate in the training, and that helps eliminate some of the potential selection bias. But practice participation was not a requirement for the trial. The kids were included regardless. And for that matter, individual affiliation with a practice was not a requirement for the data to be included. So it was truly population-based. And then in the population-based arm, all eligible children, regardless of practice affiliation, would be included in the trial. And the analysis was really a population-based sample. So one of the next things we had to think about was what counties. We decided on counties in Colorado. We wanted a minimum of 70% of the eligible children in CIS. So we looked at populations and estimated the percent of children in CIS. We included urban and rural counties, but as Allie mentioned previously, frontier counties with very small populations were excluded. No ongoing existing countywide reminder recall, because that would contaminate our efforts. And then there were some other county-specific exclusions, such as high refusal rates, and Broomfield County at that time was just brand new and a small urban county, so we didn't include them. So addressing one of our largest concerns at the design stage of the study and the initial implementation stage of the study, we had relatively few units for randomization, and there was a lot of heterogeneity among the clusters. Imbalance in clinical trials isn't a new problem, but there had not been a lot of methods at that time to deal with it. Stratification can be used, but it doesn't always overcome the problem. And one of the motivating factors for me particularly was a previous trial where we used stratification and had imbalanced study arms. So we're trying to avoid that. Some minimization methods had been proposed for individual level randomization, and these were extended to cluster randomized trials in the early 2000s. I'm just going to briefly go through this. There's a method called Covariate Constrained Randomization that was described in the early 2000s. At that point, however, relatively few cluster randomized trials had actually used these approaches, but we decided it would be worthwhile to explore it and see if we could make it work. So the procedure it's fairly simple. You have to have baseline data on the units of randomization. You generally generate all possible randomizations of units into study groups for a 2-arm trial. There's some extensions for 3 or more arms. And then calculate something called a balance criterion, which is defined as the sum of squared differences between study groups on relevant standardized variables. You can use a weight. We did not use a weight in this study, but it can be done. And then establish a criterion for the maximum difference between study arms, and that defines a set of optimal randomizations. And then from that set, you randomly select one randomization. So in this trial, we generated all possible randomizations using the SAS PROC-IML. We standardized the randomization variables just using z-scores, but there are other possible approaches. We generated a huge file containing the data on each possible randomization, calculated the means and differences. We weighted variables equally, and then computed the balance criterion for each possible randomization. Now, stratification variables can be included in the process by initially limiting all possible randomizations to those that are balanced, or you can randomize separately, say for rural and urban. So it could be done a couple of different ways. In this case, what that would involve would be each study arm should include exactly 4 rural counties, and other combinations are eliminated if we included it in the initial procedure. And it results in a smaller set of possible randomizations. Again, here are most of the balance variables that we used. I think we had one that was a little bit different, but it's pretty much the same. Total number of children in the age range in the county, up-to-date rates for early childhood immunization. We had some race ethnicity variables, average income, pediatric to family medicine ratio, because there are some differences in practice type constellation across the counties, and the number of community health clinics. So we computed this balance criterion for all possible randomizations and examined the distribution of the balance criterion and set a value. Now in the literature, there are no set rules. Some of the authors who have used these approaches have targeted the best 10%, but there's not a hard and fast rule. At that point, if you're interested, and we did this, you can compare differences in means on raw variables for the optimal set versus others, just to show that the procedure worked, and I have that here. And then we randomly selected a final randomization. So here we have rural and urban counties combined, and information on the variables that we used in the procedure. And what you can see is there's considerable heterogeneity in terms of number in children. Look at the range from 234 to over 12,000. Up-to-date rates at baseline, there are large differences, 27% to 54%. There are racial and ethnic differences, which may or may not affect outcomes, but they certainly can. And certainly average income, quite a bit of difference there. The practice type constellations were really very different across the counties, as well as the number of CHCs, community health centers. So what you can see is that if you used a simple randomization approach, you could very likely end up with extremely unbalanced study arms, and that would hurt the trial. It would definitely cause problems. So the distribution of the balance criterion We decided on that little group in red. It's actually non-overlapping, but where I set the cutoffs for the histogram, it looks like it is. And what you see from this is it's a pretty tight range of differences between study arms, but there are huge possible levels of imbalance that could happen in a simple randomization procedure. So here we compared what the differences, its absolute value of the differences between study arms for each randomization and the optimal set compared to the remaining randomizations. And you can see that it improves your situation quite a bit. For instance, differences in the number of children in the age group, up-to-date rate differences, up-to-date at baseline, pediatric to family medicine ratio. There are quite a few things there that it improves. So the next thing we did was to look at the worst randomization from the optimal set. And even there, it's not too bad. If you look at the differences between the two assigned study arms for the worst randomization, there's really nothing that's terribly different there. So finally, we come up with our selected randomization for the study, and I went ahead and separated these out into rural and urban because you can see a little bit differently how well they correspond. And they're fairly well balanced. There are some slight differences, but there's nothing major. So this procedure worked pretty well for us. We were satisfied with that. Now, one of the next challenges that we ran into was establishing the cohort, and I'm looking for Brenda out there. Yes, Brenda Beatty is one of my collaborators on this project and just did amazing work, and I want to thank you again. Brenda got the baseline cohort from CIS in June 2010, identified all the potentially eligible children who needed one or more immunizations and was in that age range, and then had to get another database from CIS at the end of the study after the intervention period was over. And the final analytic database involved matching baseline and follow-up records. And there was a 98.3% match. So that's pretty good. It doesn't always work out that way, but this one worked well. Okay, data and analytic challenges. The analytic approaches are fairly straightforward for this trial. We had one major challenge that I want to talk about. We used generalized linear mixed effects models. Our fixed effects included study arm, county baseline, up-to-date rates, urban, rural location, and then we adjusted for clustering. Now clustering, we decided we were going to have to adjust for site of last service. That was what we could get in the CIS database. Most children were assigned to a cluster in this way. One of the things that happened in this trial, this is kind of a true confession, was that there were a number of children who had no practice affiliation, or there were numerous very small clusters. And if we allowed them to be their own cluster or had clusters of 2 or 3 kids, something like that, our models wouldn't converge. So we were trying to decide, here we've got this problem, what do we do about it? What we decided to do was within each county, for the very small clusters in the singletons, we aggregated them into a single county level, quote, unaffiliated cluster. And that actually worked quite well. And then again, we had some secondary analyses around whether reminder recall was used at all. Now, I'm not going to go into results because they've already been presented. The conclusions are that cluster randomized pragmatic trials present unique challenges, but we felt like in most situations we could find reasonable, not perfect, but reasonable solutions to study design, data, and analytic challenges. And finally, I want to thank Brenda because we did this hand in hand all the way through, and Allie, of course, and we'll do questions later. Okay?